very grateful to be here today with Dr. Elizabeth Ellis, and she is going to run through the data that was presented at Asco GU. So Asco GU is a large medical conference that presents the latest research specifically for GU cancers like kidney cancer. And chromophobe kidney cancer actually had 4 abstracts that were presented in the poster session this year. And Dr. Ellis had one of those abstracts that was included. So when you hear about research at a poster session like Asco or Asco GU, it's important to understand what that means. Poster session is essentially where researchers display summaries of their work on large posters, and then the attendees can kind of browse through those posters and get caught up on what the latest developments are. You can kind of think of those posters as the scientific equivalent of a science fair for medical researchers. They allow them to investigate preliminary findings and share their data with each other, even if it may not necessarily be ready for publication yet. It's important to recognize these limitations as we explore this work, as this initial work that Dr. Ellis is going to share with us is about a small cohort of patients with chromophobe kidney cancer. So this is research that hasn't made it to publication yet, but is really great data to explore and to share what future efforts in this area might look like. We welcome Dr. Ellis, who is a urologic oncology fellow at MD Anderson Cancer Center, to share from her poster during the session at ASCO GU, investigating prognostic biomarkers in chromophobe kidney cancer. Can you share with us a quick summary of this abstract and the work that was presented?
Yeah, sure. So this work all started that when I was a urology resident, and I was really frustrated by the fact that we can't tell with great certainty which tumors are aggressive and which are not, aside from relying on tumor size, pathological grade, and stage. And so this is especially difficult in chromophobe kidney cancer because it's much more rare, and so the numbers are a lot lower. It represents only 5% of all kidney cancers. While it generally has a favorable prognosis, 5 to 10% of patients will develop metastatic disease, or also known as spread outside of the kidney. So to answer this question, we constructed a tissue microarray using tumors from 46 patients with chromophobe renal cell carcinoma who had their tumors surgically removed and at least 3 years of follow-up. A tissue microarray is a small block, and it contains multiple samples of tumor tissues from multiple patients, and it can be used to compare test results across different tumors. So we then stained for proteins within this tumor tissue, and these proteins are known to help cancer cells multiply and spread. And we compared the intensity of the staining between the tumors that had a recurrence or metastasized and those that did not.
That sounds like really important work and a very helpful way to be able to look across the responses from several different patients all at once. What were the preliminary findings that you found through this research in that study?
Yeah, so we had 46 patients and 6 experienced a disease recurrence. 2 of those developed distant metastasis and 4 had local recurrences.
And can you explain the nuance or the difference between what a local recurrence is versus distant metastases?
Sure. A local recurrence in kidney cancer is cancer that recurs in the same kidney after it has already been treated. Metastasis is when the cancer spreads outside of the kidneys, such as to places like the lungs, lymph nodes, or liver.
Given the context of the 46 patients that you had, that kind of is in the ballpark of what we'd expect to see from like metastatic disease, even though that's a small cohort. What were the other findings that you ended up coming across from your work?
We were able to identify a potential protein expression signature that's associated with recurrence. What this means is that there were different patterns of staining intensity of the proteins in the tumors that recurred or spread versus those that did not. And when we combine these markers as a panel, having 2 or 3 of these patterns was associated with a higher risk of recurrence. I have a picture here, and it's an example of an aggressive subtype shown in the top picture, and it has lost the expression of a protein for which we were staining compared to the non-aggressive tumor shown in the bottom picture. These associations were statistically significant in our small sample, but these are still only preliminary findings that need much more rigorous testing before they can be considered clinically meaningful for patients.
If these findings are validated, what would their significance be clinically?
Yeah, if these are validated in larger studies, the signature might provide insights into the biology, like you said, of chromophobe renal cell carcinoma, that is more likely to be aggressive. My ultimate goal, though it will take a while, is to use this data to be able to tell from a biopsy how aggressive a tumor is, or use this to develop imaging targets that can tell us how aggressive a tumor is and help us guide treatment decisions on an individualized level. What's potentially valuable about this panel is that it uses standard immunohistochemistry, and this is widely available in pathology laboratories, making it practical and cost effective if proven reliable.
So this would be staining similar to what like a pathologist already uses when a patient goes for a biopsy or they have surgery and they see those stainings in their pathology report. That's using a similar process, correct?
Exactly, yeah.
Since this work is in the early stages, if it's validated by others, it could still be a few years before it would make it into any type of clinical practice. And sometimes this early research doesn't always end up making it into clinical practice. I know one of the determining factors of if that can be possible or not depends on if there is funding and other samples to validate this work or for it to be validated by another group. And so I know you recently also received a grant from COA and the KCA in 2024. Will this funding help further these findings or understand the biology of chromophobe RCC a little better?
Yes, we are currently developing another tissue microarray with many more aggressive tumors that have metastasized or spread outside of the kidney. And this will give us the numbers we need to externally validate our previous findings at a different institution. And we're also using this grant funding to explore some other exciting new insights about the biology of chromophobe RCC.
So this is kind of how you take these really small kind of initial samples of you're trying to see if this is an area worth investigating, and then you expand that to get meaningful numbers to actually bring it to clinic.
Exactly. It's certainly a process. You need the preliminary data before you can start expanding those efforts.
Well, thank you for sharing your research and this information with us. If there's a message you'd like to share with patients who have chromophobe RCC, what message would you like to share with them?
I'd like patients to know that while chromophobe RCC research has historically received less attention than clear cell RCC, there's still growing interest and investment in understanding this subtype better. And we're working hard to better understand this disease and bring better treatments to patients.
Thank you for sharing that with us today. We look forward to hearing from you again, hopefully in the near future, as your data from the 2024 Chromophobe Focus Grant matures. So thank you for spending this time with us.